Cameron Eldred here, doctorate in athletic training student through Indiana State University. And today we're going to be talking about improving patient outcomes through two different mobilization techniques. We're going to be talking about the Maitland technique versus the Mulligan technique. So the first one that we're going to go ahead and talk about here is going to be the Maitland technique. Maitland technique of mobilization is more of a traditional technique focusing on arthrokinematics of a joint and the concave-convex rule. Now, Maitland created a scale talking about the 5 grades of joint mobilization that we'll talk about here in just a moment. This targets an interarticular tissue instead of the surrounding musculature and can involve oscillations, sustained translatory guides, as well as manipulations. This treatment is also focused on identifying and correcting symptoms. Now, the theory comes onto the convex on concave rule. The motion is achieved by using joint play and articular surface motions. Convex, moving on concave, the concave portion is stabilized, and the convex glide moves in an opposite direction of the joint or the bone movement. And then concave on convex, concave is stabilized, and the glide is performed in the same direction of the joint or the bone movement. So we're using joint play and articular surface motions to target treatment at improving the particular motion. Now, the Maitland application, we're going to be looking at grades and uses. So grade 1 to 2 can be used for daily pain relief, as well as the joint play is small and does not go to the tissue barrier. Grade 3 to 4, this is used about 3 to 5 times a week for joint stiffness and hypomobility, as well as it uses large mid-range motions and up to oscillations at the tissue barrier. Now, grade 5, this is going to be a joint manipulation. This is a small, high-velocity mobilization that usually causes some type of an audible pop. So it's just a quick jerk that usually will result in that pop that you would hear. Now we're going to jump over. We're going to talk a little bit about Mulligan's technique. So this technique focuses on joint mobilizations with movement. You'll hear this called MWM. This uses a sustained passive accessory glide while the patient performs problematic active movements, and is based around the use of those natural apophyseal glides or snags. So after a joint has been identified as pathological, the clinician will then apply a certain force with movement, which helps reduce the symptoms while remaining in a pain-free range. Again, this technique is largely focused around being pain-free. So you don't want to cause the patient any pain, whereas with the previous technique, a little bit of pain is okay. This one, if you're causing pain, you would move the patient and then try again. There is no set scale for the Mulligan technique. And if the technique does not reduce or eliminate that pain again with overpressure at the passive end range, you need to adjust the technique. Now, in theory, positional fault hypothesis, which is correcting a positional fault or bony incongruity that's present after injury. These faults are only presumed present after positive results of an MWM technique, although some imaging studies have seen faults in some joints. Forces need to be applied in a specific direction, force, and location, which might also cause a neurophysiological mechanism for pain release. Now, Mulligan application. We identify the client-specific impairment measure and the motion limited by, or this would be the motion limited by pain or joint stiffness. The passive accessory force is usually translatory or rotational and should be applied at the joint line by the clinician's hands. They can be belt assisted. Sometimes you can even use tape for these types of things. mobilizations can be altered based on the location, force level, and force direction. And remember, both the glide and the movement need to be pain-free. Now, there are certain similarities. The Maitland and the Mulligan techniques both believe in the goal of increasing tissue mobility as well as capsular range of motion. They both believe in reducing patient pain through nociceptive response. And finally, they both work to increase patient function of the affected joint. So they both are repositioning the joints, correct joint tracking. They both can alter direction, magnitude, and location or force. They both have very similar treatment goals. They require constant communication. Neurophysiological effect is very similar for both of these. So there's quite a few different things that you can look at that are similar. So we're looking at increased range of motion, decreasing in pain, restoring joint position, decreased risk of future injury, and decrease of functional limitations and disabilities. So as you can see, this is the list that you're seeing is very small and can grow immensely between the two. Now, there are a few differences. So oscillation or manipulation with no movement versus a sustained glide during motion. One allows minimal pain versus one that does not allow any pain at all. MWM also allows for patient education and self-treatment. You're able to provide the patient with different educational materials, with demonstrations and such that can allow them to treat themselves if you're not able to see them on a frequent basis. Next, we are going to look at clinical focus, or my clinical focus for this, which was treatment of the knee flexion in patients with knee osteoarthritis. This is actually kind of important to me. My grandfather recently had a complete knee replacement because of osteoarthritis in his knee. So that's why I chose this disorder to look at. Now, a couple of facts. Knee osteoarthritis is the most common joint disorder in the United States. It affects approximately 10% of men and 13% of women age 60 and older. There is also more than 7 million people in the US that it affects. Osteoarthritis can cause pain and disability that's associated with muscle degeneration, crepitus, decreased range of motion, joint stiffness, and other symptoms. Joint injections, so injection surgeries, medications, they've all been used to assist in those suffering from osteoarthritis. However, physical therapy and exercise have been clinically shown, again, to improve the range of motion and decrease the amount of pain that somebody is currently in when it comes to this disease. So the study that I looked at used both Maitland mobilization and Mulligan mobilizations with MWM approaches, and they've both been used clinically for pain relief and improving mobility in an osteoarthritic knee. However, a lot of the experimental evidence supporting the usage of the mobilization techniques as just sole interventions and management of osteoarthritis is insufficient. Many have shown that MWM has a quicker response, but again, they both kind of come out on top equal with each other. So the study that I looked at, again, it took 30 subjects and split them into two different groups. One group was given the Maitland technique. They were randomly allocated. One was given the Maitland technique first, followed by the Mulligan. The other was given the Mulligan technique, followed by the Maitland. There was a washout period of 48 hours in between those interventions, and the outcome measures that were used was the numeric pain rating scale, timed up and go test, as well as the pain-free squat angle. They were measured before and immediately after both interventions. So this study that I looked at used repeated measures, ANOVA, for analysis of the outcomes. And the conclusion that they came to was that it can be seen that both Maitland mobilization as well as the Mulligan MWM, both are equally effective in osteoarthritic knees when it comes to reducing pain and improving functional mobility and pain-free squat angle immediately post-treatment. Um, there were a couple of other articles that I had the opportunity of looking at. One of them was just MWM for OA, and that was 14 females, 5 males with OA. They used passive flexion and extension range of motion. They used the ADL scale, and all of them used outcomes to measure the initial effects of MWM, both clinician and self-MWM. Techniques that were used were non-weight bearing progress to weight bearing when pain-free. In 11 patients who required lying MWM due to pain, all were able to weight bear after 1 set. There was no increase in symptoms or pain. Significant improvement from baseline were seen in flexion and pain scores within 15 days. So obviously, MWM can do wonders for a patient. There was another one that was specifically for Maitland mobilizations that I had looked at. There were 143 patients with osteoarthritis who were put into a clinical treatment or home exercise plan groups. Patients had crepitus, knee pain, stiffness, and bony enlargements, all for diagnosis. Treatment group received personalized manual therapy and supervised exercise programs. WOMAC and walk tests were used as outcome measures, and treatment groups were less likely to be taking medication and reported being more satisfied with their care, as well as 2 times greater WOMAC improvement after 1 year. So obviously, both of these alone showed great, significant increases in range of motion, significant decreases in pain. It just looks like the MWM, of course, took a little bit longer. So as a conclusion, from my opinion, or the MWM was a little bit quicker. So in my opinion, both techniques provide the significant relief to patients with knee osteoarthritis. However, it has been shown that MWM does have slightly quicker results. So, for those who are looking into this, this is one that I would definitely recommend continuing with. Thank you. Have a wonderful day.